Welcome to a webinar on routine vaccination recommendations for dialysis patients. The objectives of this presentation include common vaccination recommendations for dialysis patients, high risk of morbidity and mortality from preventable infectious diseases, and special considerations for dialysis patients. Infections are the second most common cause of hospitalization and mortality in end-stage kidney disease patients. They have higher annual mortality rates due to sepsis compared to the general population. One of the challenges is the immune response to most vaccines in dialysis patients that are less effective compared to the general population. Patients with advanced chronic kidney disease are at higher risk of infections. They are generally older with high number of comorbidities and compromised immune status. Nursing home residents, the patients who share transportation to and from dialysis, and in-center hemodialysis patients in close contact with other patients are at increased risk of infections. Their lower response to vaccines could be attributed to several white blood cell factors related to their quantity as well as functional quality as listed here. First, let's look at influenza vaccination. The graph illustrates a seasonal variation in monthly mortality among dialysis patients over a 5-year period, with the peaks coinciding with the winter months, with the exception of 2020 due to the COVID pandemic. The intensity and timing of influenza-like illness is associated with similar intensity and timing of deaths in end-stage kidney disease patients, with their peaks during colder months each year. Every 1% increase in quarterly influenza-like illness was associated with 1.5% to 2% increase in relative mortality. Seasonal variations were similar across different regions of varying climates. Seasonal variations were also observed in neutrophil to lymphocyte ratio and laboratory test results such as serum calcium, potassium, and platelet counts. When adjusted for these clinical variables, seasonal mortality differences were no longer seen. In a retrospective study involving nearly 37,000 dialysis patients from 900 centers across 3 networks during the 2005-2006 influenza season, mortality differences were noted based on vaccination rates, with the most favorable being for patients who received both influenza and pneumonia vaccines compared to neither. Influenza vaccine is recommended for everyone 6 months and older, with a few exceptions. The injectable formulations are either inactivated influenza vaccines or recombinant influenza vaccine, whereas the nasal spray is the live attenuated influenza vaccine. The injectable flu vaccine is generally recommended for patients with chronic kidney disease, whereas caution is warranted with live attenuated influenza vaccine. Augmented vaccines are approved for people 65 years and older. Flu vaccine is typically administered during September and October, though it is not too late beyond this period, and flu vaccine should be offered throughout the influenza season. For the last flu season, all flu vaccines were quadrivalent against 2 influenza A and 2 influenza B viruses. Most flu vaccines were manufactured using egg-based technology, though an egg-free, cell-based quadrivalent vaccine was also made available. It is now recommended that people with egg allergies can receive any licensed influenza vaccine that is otherwise appropriate. People who have a history of severe egg allergy should be vaccinated in a medical setting supervised by a healthcare provider who is able to recognize and manage severe allergic reactions. Flu seasons vary by the regions of the world. For instance, in the Northern Hemisphere, the flu season can begin as early as October and can last as late as April or May, whereas in the temperate climates of the Southern Hemisphere, influenza activity typically occurs during April through September. Travelers should consider these regional differences and get the flu vaccine at least 2 weeks before travel. Next, let's review the pneumonia vaccination. People with chronic kidney disease are at higher risk of pneumococcal disease and prone to its complications. In a USRDS study of nearly 300,000 dialysis patients, 1 in 5 developed pneumonia within 1 year of starting dialysis, and 42% of these individuals required hospitalization. Overall, the mortality rate from pneumonia is 14 to 16-fold higher in patients on dialysis than in the general population. In another study comparing patients with and without chronic kidney disease in Taiwan, chronic kidney disease was associated with increased risk of pneumonia with an overall hazard ratio of 2. The patients undergoing hemodialysis might be particularly susceptible to pulmonary infections for several reasons, such as transient hypoxemia during the dialysis procedure, exposure to other patients and staff at the dialysis facility and during shared rides to and from dialysis, weakened immune system, and multiple comorbidities. Until recently, 2 vaccines, the 23-valent pneumococcal polysaccharide vaccine, PPSV23, and the 13-valent pneumococcal conjugate vaccine, PCV13, were recommended for US adults. Pneumococcal polysaccharide vaccination was not highly protective against pneumococcal pneumonia without bacteremia. Introduction of pneumococcal conjugate vaccine that are efficacious against non-bacteremic pneumonia resulted in a major reduction of pneumococcal disease burden. Per the updated CDC pneumococcal vaccine guide, there are 2 newer vaccines licensed for use in adults 18 and older. 20-valent pneumococcal conjugate vaccine, also known as Prevnar 20, and 15-valent pneumococcal conjugate vaccine, Prevnar 15. The various pneumococcal vaccines target different serotypes, as shown here. No vaccine is 100% effective at preventing disease, but these pneumococcal vaccines are considered safe and effective to help protect against pneumococcal disease. For adults 18 and older with chronic kidney disease, pneumococcal vaccination recommendations are as follows. Individuals who have never gotten any pneumococcal vaccine may receive either PCV20 alone or PCV15 plus PPSV23 after 1 year. For others who receive PPSV23 only, either PCV20 or PCV15 may be administered at least 1 year after their most recent PPSV. If PCV13 and or PPSV23 were already administered, then PPSV23 may be given as previously recommended, or 1 dose of PCV20 may be used if PPSV23 is unavailable. Pneumococcal vaccines used either alone or combined with influenza vaccination in dialysis patients are effective and safe. A meta-analysis study revealed that compared with no vaccination, those who received both influenza and pneumococcal vaccines had nearly 30% lower all-cause mortality. Next, let's spend a few minutes to review hepatitis B vaccination. Viral hepatitis B prevalence is higher among hemodialysis patients compared to the general population. Viral hepatitis transmission in hemodialysis was first reported in the 1960s and continues to date. Hepatitis B surface antigen has been detected on numerous hemodialysis facility surfaces, including hemodialysis machine control panels, doorknobs, clamps, and scissors. Dialysis staff can transfer virus to patients from contaminated surfaces by their hands or gloves, or through use of contaminated equipment and supplies. In addition to contaminated surfaces, cross-contamination to patients in dialysis facilities were also attributed to multi-dose medication vials and intravenous solutions that were not used exclusively for one patient. Injection medications that were prepared in spaces adjacent to areas where blood samples were handled, and dialysis staff who simultaneously cared for both HBV-infected and susceptible patients. Even in the absence of visible blood, HBV can remain infectious on environmental surfaces for 1 week or even longer. The risk that a non-immune individual with exposure to HBV-infected source where seroconvert is as high as 30%. Hepatitis B vaccine is especially relevant for dialysis population and highly effective in preventing hepatitis B infection when successfully vaccinated with adequate immune response. Higher doses of certain vaccines are indicated for adults on hemodialysis and other immunocompromised adults aged 20 and older. Commonly available hepatitis B vaccines and their dosing regimens are shown here. The newer vaccines, such as Hepatitis B, have simpler dosing recommendation. Hepatitis B vaccine is encouraged before the patient starts hemodialysis. In a small Canadian study, the patients with the lowest level of kidney function and who were older and had diabetes were less likely to seroconvert. Patients on dialysis have shown a diminished response to the HPV vaccine over time. This is especially applicable to low responders, as shown on the left panel. Therefore, ongoing post-hepatitis vaccination response monitoring is crucial. HPV antibody titer should be assessed 1 to 2 months after the final dose. If the titer is less than 10, repeat dosing and subsequent antibody titer in 1 to 4 months should be considered. The need for booster doses should be assessed by annual testing for antibody to hepatitis B surface antigen and booster dose administered when the level is less than 10. If the titer remains below 10 after above steps, monthly hepatitis surface antigen monitoring is indicated. Finally, a few points on zoster vaccination. The recombinant zoster vaccine is currently recommended for adults aged 50 years and older, regardless of prior history of receiving an alternate zoster vaccine or having zoster infection. This zoster vaccine is also recommended for younger patients between the ages of 19 and 49 years who are or will be immunodeficient or immunosuppressed because of disease or therapy, including advanced chronic kidney disease and dialysis. Zoster vaccine should not be administered to a person with a history of severe allergic reaction, such as anaphylaxis, to any component of this vaccine, and anyone experiencing an acute episode of herpes zoster. The general guideline for any vaccine is to wait until the acute stage of the illness is over and symptoms abate. As a final reminder, it is important to recognize that vaccination recommendations are periodically revised. Please refer to the latest CDC and the Advisory Committee on Immunization Practices recommendations for timely guidance. Thank you.